Well, are we just about all met?
We're doing pretty good. Yeah, I think we've got. Is Jess here? Yeah, I can see Jess. Yeah, I think we're good to go.
Good. Well, welcome everybody. Talking about electricity down, it feels like the end of days, but that's not the mood that we want for this commission. We want reconstruction, positive, creating good things. And I think we've had a very good kickoff, which had a lot of that mood. These next two sessions are very much about listening, which for some of us is extraordinarily difficult occupation. We're much more used to talking or somewhere in between interrogating. But the way we've got these two sessions structured, there won't even be very much interrogating. It's really mainly listening. This session, we've got Health and Wellbeing Boards from 4 areas talking to us, and the next one will be place-based partnerships on the 6th of December. We've got 20 minutes. Jenny, I had 2 slightly conflicting things. One said that you were going to be talking about community journalists and the other one didn't.
No, I wasn't. Not this time.
Okay, fine. So the idea is that we'll have 4 presentations. I'd really like to hear from our 4 leaders, council leaders, at the end of it. We won't have time after each of them to do the kind of interrogation that we would normally like to do and conversation. But at the end, to kick us off, Philippa, Stuart, Lynn and Mohammed, we'd very much like you to just a couple of minutes each to your reflections on what you heard, because we've only got a short time for discussion at these 2 sessions. There'll be ample time as we then digest what we've heard subsequently, as the Commission then reflects on it and completes its work. And the kind of questions, and so to our leads, to the Health and Wellbeing Boards who are presenting, it'd be extremely helpful if you didn't cause me a problem of timekeeping and you kept very carefully to your 20 minutes and not go over that. I know it's limiting, but there's 4, we've only got 2 hours and we need a bit of time for reaction. And the kind of questions that this commission is dealing with are how do we get the various parts involved, which means local government, the NHS, integrated care systems, business, public services, the community and voluntary sector, including faith-based communities. So all of those, and we've been having quite a lot of discussions in different parts of the country recently about businesses, which is relatively new. But how do businesses get involved, as well as the others which we're more familiar with? We also need to be thinking about the funding issues. Dominic, you talked about that at our last meeting, joining budgets, commissioning for social value, commissioning for prevention. And then key to everything that I've been doing for the last nearly 50 years, talking not just about population level, but about equity. And that means, yes, people tend to focus on poverty, but it's not only poverty, it's the gradient. It's inequality, degrees of deprivation. And we see that, and the data from this part of the world show that if even the best off are only at around the England average in terms of life expectancy, we're dealing not only with poverty, but with degrees of deprivation, with the gradient. So that's what we're trying to understand, and it's all in the context of what can happen at local and regional level, despite what is or isn't happening at national level. Now, we'd like to be able to influence what's happening at national level, but the real question is what can happen at local, at city, at regional level, whatever is happening at national level. So that's where we are. And as I say, we're going to hear from 4 health and wellbeing boards. And if we could start with Blackburn, you notice that I've set the tone. I only used 6 minutes of my 10-minute introduction. So if you could please help me by keeping within the scheduled time. So if we could start with Blackburn. And you'll keep within the time if you keep muted. There's no question about that.
Could I ask if Howard could share my slide set? I'm having a problem with my sharing function. So if that's possible, Howard, that'd be great. Howard, let me know.
Give me 30 seconds.
Right, brilliant. So I will just give you the background to our presentation. We did have a Health and Wellbeing Board presentation a couple of weeks ago of the plan for the Health Equity Commission. We discussed a series of priorities in relation to the data across Blackburn with Darwin, and we made some high-level recommendations at a strategic level. So what I will do is just go through very quickly a summary of that. Thank you, Howard, that's great. So next slide, please. I can pretend to be the CMO. Just to remind everyone about the ask, our 5 priority areas and what we think are priority actions for us. Next slide, please. And next slide. So just to remind everyone, these were the questions we were trying to answer as a Health and Wellbeing Board in terms of feeding back into the HEC. Next slide, please. Next slide, please. So one of our key priorities, priority 1, was to address the inequalities we have in Blackburn with Darwin in relation to early years. And to illustrate that, we've just showed there on the slide, we have the 3rd highest child mortality rate. Now, we're fairly sure that this year, when we get the data, because that data only goes up to 2019, this year when we get the data, and next year we'll probably be 1st or 2nd worst. Child mortality is a relatively new indicator, and it's deaths of children from age 1 to age 17 up to 18. So that's our number 1 priority for the next generation. Next slide, please. Our second priority is good quality employment and economic growth. Blackburn with Darwin has the 2nd lowest income per household in the country, and that affects an enormous range of health and well-being, economic, social and other outcomes across the borough. And we want to reduce the high unemployment, particularly in BAME South Asian women, where we have high qualifications in many of that younger generation, but low job opportunities locally. And there are some a range of things we think we could do about that collectively with our economic partners. Next slide, please. Housing. One of the problems in Blackburn with Darwen, as in much of East Lancashire, is that we have a very high percentage of pre-1919 terraced housing, much of which is in the private housing sector. And one of our problems is we don't have all the strategic instruments we would need to improve the quality of that housing, but we think that's critical to improving health and well-being across the borough. So some of what we would want to do is get more local control over standard setting, inspection and legislative control over private sector rented housing in the borough. Next slide, please. Clearly, much of East Lancashire, Blackburn with Darwen in particular, has a high black and ethnic minority population, mostly South Asian. Reducing inequalities in ethnic minorities is going to be one of our clear priorities. We have just over 30% of our population in an ethnic minority heritage group, and improving both health outcomes but also access to services is going to be critical for this group. Next slide, please. One of the things the pandemic has taught us, and Blackburn with Darwen is the highest impacted local authority from the COVID pandemic. We have the highest cumulative case rate, the most people infected in the country as a percentage of the population. One of the things that's become very clear from our experience there is that community and neighbourhood capacity to improve health and well-being outside of the NHS, outside of even local government, needs to be strengthened and enhanced. And to do that, we need to, all of us need to be resourcing the community and voluntary sector infrastructure to a much greater extent and supporting community development and neighbourhood development. And this model here is a model from Shared Lives Plus, which is probably one of the most comprehensive I've seen. We have quite a lot of elements of that, but it needs enhancing, supporting and resourcing from all partners if we're going to make a difference to the resilience in the population, the capacity of the population to manage their own health and well-being and the determinants of their own health and well-being. Next slide, please. So now I want to just focus on what we think are agreed priority actions, and here we focus more on systems and capacities rather than just listing, you know, we need to reduce the high rate of type 2 diabetes, etc. The problem for Blackburn with Darwen with our health and well-being status, which is that we have amongst the lowest life expectancy and lowest healthy life expectancy in the country, is that almost any disease or illness you can name, we are worse than you would expect, worse than the England average. So we think there are a number of high-level priorities that need to be addressed as part of the health equity review. Next slide, please. The first one is that we're quoting here from a report by the BMA called Prevention Before Cure, and the quote is that preventable ill health accounts for an estimated 50% of all GP appointments, 64% of outpatient appointments, and 70% of all inpatient bed days. Now, if that continues and we fund the NHS in the current model, the NHS will not be sustainable in another decade. And we need to move from detecting and managing disease and illness to predicting and preventing it. And to do that, we need to do a lot of the things that we've set as priorities. And we have a feeling that the NHS is a little bit like operating a model implicitly and explicitly that is a bit like the early motor cars, where when they were first designed, they couldn't imagine that it would be anything different to a horseless carriage. And of course, the NHS started off in 1948 being hospital-centred, dealing with urgent periods of acute illness where hospitals were necessary to save lives. Now, the majority of the challenge is to do with long-term conditions, preventing and supporting people in those conditions, but particularly preventing them. If 70% of them are preventable, all hospital inpatient bed days, that's where we should be putting the money. But the system as a whole is putting the money at the wrong end of the problem. So until that's addressed, we feel that we cannot be effective in addressing some of those priorities. Next slide, please. One of the things we've learned from COP26 is that you need public service systems, governments and politicians to address the challenges, but we also need to mobilise the public to generate the demand for those changes and to support the changes that would be needed, even if they're slightly unpopular. And we think we need to modernise the NHS governance models to take account of what's called smart governance, governance for health rather than just governance of the healthcare system. And that needs us to enable to do more things like citizens' juries, more of the sorts of things that we're doing with citizens journalists, for instance, saying these are the things that are making us ill, these are the changes that would make a difference. Please, can you, the public sector, change the way you operate, change your operating model and give us health as an outcome of public policy through addressing the social determinants of health. And we think our governance model of health, for health, both need changing. Next slide, please. We feel we need to reinforce local and regional capacities, particularly to ensure local authorities have powers to modify the local determinants of health. And they may be in areas of planning policy, transport policy, housing policy, as I've mentioned. And we need to use our local assets to generate well-paid work and sustainable economic growth. Next slide, please. We need to establish robust health equity delivery mechanisms. One of the reasons we've failed to address the gaps in life expectancy and healthy life expectancy in our populations compared to the England average is that we simply haven't had the delivery mechanisms capable of making that a reality. We've had health inequality targets for 30 years and health inequalities are now worse than they've been for those 30 years between rich and poor. So we think the problem isn't that we need more targets, we need more services. What we need is the right levers and incentives, the right capacity, performance management, the right reward system in the services that we provide to ensure that investment is made and outcomes delivered to reduce health inequalities. And at the moment, particularly the NHS only tends to reward and pay for activity mainly in the secondary care sector. Until we address that, until people get paid and rewarded for reducing inequalities, it's unlikely to happen. So we think we need a focus on delivery mechanisms. Next slide, please. The National Audit Office have done a lot of work and there is a science around this. I won't go into the detail there, but it is there on what an effective delivery mechanism would look like. Next slide, please. And work that was undertaken that I was involved with Sir Michael Marmot in relation to the European Marmot review did look at what were effective health equity delivery systems. And it looked at the system's characteristics and drew evidence from global sources and came up with 11 systems characteristics of an effective health equity delivery system. And I think one of the recommendations we need in order to achieve the outcomes of reduced health inequality is to ensure that whatever system we end up recommending, it fulfills all of these objectives. And that will be critical because setting programs, setting targets, getting commitments, even putting some resources in, all of those things have not delivered improvements in health equity. And partly it's a systems problem. And the systems problem is that we haven't taken it seriously enough. We haven't designed a system capable of delivering the outcome we desire. You know, every system is perfectly designed to deliver the outcomes it does. And our system is perfectly designed not to deliver improvements in health equity. So we need to use some kind of checklist like this to make sure not only that we have the intention, but that we have the capacity to deliver on improvements in health equity. Last slide, please. And this is my last slide, and really this is not a political point, but just a practical one. And there is an elephant in the room in this discussion, which is that local authorities that are enduring the worst health inequalities have had the most cash taken out of them, out of their core budgets, since 2010. And that red arrow is pointing, this is all the upper tier local authorities in England. This is only data to 2016 and 17 from 2009-10, and it looks at the percentage even at that point that had been taken out of core budgets. Blackburn with Darwin, along with many other local authorities in Lancashire, have had an enormous amount taken out of their core budgets. And it's worth remembering here that local authority services, mostly in first tiers that do adults and children's and public health, most of those budgets, about 80% of local government spend, is on the 5% of the population who are most vulnerable. And so that withdrawal of resourcing for everything from Meals on Wheels to adult social care and to children's services, the early years interventions in particular, all of that money that's been taken out has reduced our capacity to address the social determinants of health in our population. So we are expecting a levelling up white paper from central government, which will be really welcome, but it's going to have to work very hard to compensate, or at least get us back to where we were in 2010 in terms of our capacity to deliver improvements in life chances for our populations. And we will need to address that issue in the final Marmot recommendations, in our view. Thank you very much.
Perfect. Thank you so much, Dom. Really interesting. And for one, I'm going to need to look at the slides again. Just particularly that last one, I couldn't read the two axes. I'm guessing the top one was reduction in local government spending, and the bottom one was what? You're muted. You're muted. You're still muted.
Sorry, Michael. All the local authorities listed in order. The longer bars are the local authorities that had the most taken out of their core budgets in that 6-year period.
But the top graph, you had two sets of graphs. The top one was the spending, was it? And the bottom one was?
Yeah, no, they're all the reductions in spend.
Okay,
yeah.
Thank you. Terrific, and thank you for my keeping to time. That makes my task easier. So colleagues, as I said, we're going to go from one to the other. If you could remember, note down your comments so that we can then discuss it at the end of them. So let's now move to Blackpool, please.
Afternoon, Sir Michael. Afternoon, colleagues. Just going to share my screen with you. I've got 9 slides, 4 setting the context and 1 each for answering your questions. So hopefully I'll stick to time and then leaves room for discussion. So, okay, let's see if this works. Oops. So Blackpool, the watering hole of the masses. So we're Britain's favourite resort. 12-13 million visitors every year, and we continue to see us leading that popular culture that exists. So I was just in the Winter Gardens this morning, and we have some fabulous facilities, but behind it all, our stats aren't great, and I don't expect you to read this slide, but there's a lot of red on here. So from child poverty to educational attainment to our poor health stats, we are at the wrong end of the statistics. So again, you won't be able to read the detail here, but I'm just trying to illustrate the point that we are at the wrong end of the inequalities scale. I wanted to show you this because I think Blackpool is different in many respects to other deprived local authorities. So this is excess male mortality, and the shaded area is excess male mortality in other deprived local authorities. The broken line is Blackpool, and what you see here is a slightly different pattern to other deprived areas. The excess mortality in other deprived areas sort of increases with age. You can see the excess mortality in Blackpool there is in a much younger age group, and we lose a lot of young people to drugs, to alcohol, and then also with people in their 40s and 50s to heart attacks and strokes. So that gives you that slightly different pattern of mortality compared to other local authorities. So just going on to actually setting that context around our inequalities and our poor life expectancy and that early mortality, we were asked to answer these questions. And of course, you know, in terms of partnerships, this is what we do on a daily basis. You know, this is bread and butter public health, working with partners. And yes, we have currently have lots of partnerships, particularly with the business sector in Blackpool. And if you come to Blackpool, our big offices has a big Sainsbury's next to it, and we worked closely with with Sainsbury's to get people recruited into those jobs from the local community who traditionally wouldn't have had much of a chance of getting a job in an organisation like that. So that's an example of us working closely with the business community. We have a Fairness Commission. I actually chair the Fairness Commission in Blackpool. Slightly different tact for our Fairness Commission. We're not there just about outlining inequalities, but actually doing stuff. So we've delivered a community facility, a community farm, a community shop, all of those things through the Fairness Commission, along with we're a fair trade town, we've got a Dementia Action Alliance. So all of those things have been delivered through that Fairness Commission. So it's more than a talking shop. And sometimes I get frustrated with lots of talking shops. This is about delivery. This is about doing things with our community. And we've done residents' inquiries, citizens' inquiries across Blackpool, in every bit of Blackpool, really understanding our communities. There is one delivery board that's already delivering across Lancashire, and that's the Changing Futures programme, which is tackling those individuals with multiple complex needs, i.e. those people with alcohol, drugs, substance misuse, homelessness, mental health, and of course being in touch with the criminal justice system. That programme we were successful at leveraging in funding, some national funding from DLUC, and we're now tackling those inequalities for those individuals, those most vulnerable individuals across Lancashire, and that's been born out of a partnership that developed over the COVID pandemic. So the next question was, outside of the funding issues, what do you need to do to address the wider determinants of health? Before I answer this question, I think there are funding issues. So in Blackpool, particularly since 2010, £1.2 billion has been taken out of the council budget over the 10 years. So we have been hit particularly badly during austerity. I'm not making a political statement, that's just a statement of fact. What do we need to do outside of those funding issues? Well, agree a few key priorities and jointly invest. The NHS always responds to demand and not need, and that's where we need to shift things. And I think that's what Dominic was also saying. Providing services in a way people that need them, rather than providing them in a way that we do on an organisational perspective or from a professional perspective. And I use the example of the homelessness work. When the diktat came down from government about getting every homeless person into temporary accommodation, our housing officers did a wonderful job across Lancashire in actually delivering that. But then the next task was actually keeping those individuals actually in those properties, because they had other issues going on in their lives. Substance misuse, the mental health. And what we did during the COVID pandemic was We forgot about organisational boundaries. We ripped up the rule book. We forgot the criteria for many of our services, and we just delivered services to those individuals. And we listened and harnessed those with lived experience. So we delivered services according to what people were telling us they needed. Can you foresee the Lancashire and Cumbria Integrated Care Board investing in social determinants? Well, the NHS has a really bad track record in this area, and me and my team did a filed coast, along with working with SACTIS team, did a filed coast prevention strategy, a 5 to 10 year strategy. And at the time I said, we're investing a lot of time and effort in putting this strategy together and a delivery plan together. I don't want it sitting on a shelf gathering dust. And that's exactly what actually happened. It was a bit of a waste of time. We did all that work. In year one, a small amount was invested in smoking. It took us 2 years for the NHS to invest in a homeless healthcare team. Got there in the end with that. But then that programme, which was supposed to be £20 million, the acute trust overspent, and all the rest of the money went to the acute trust, and nothing was left for our inequalities programme. So I put that out there because the NHS doesn't have a great track record on this. If it's going to do it, it needs to get serious about it. I think Dominic picked up on some of these points. Some of the government policy doesn't help us at a local level. Housing particularly, housing, some of the housing policy. We have 4,000 HMOs, houses of multiple occupation. Lots of private landlords make a huge amount of money out of Blackpool from the housing benefit that comes into those HMOs. We have no control over that housing benefit. We want local control, and we've asked government to give us that local control, even piloting. Of course, poverty has a huge impact on all our stats. And the other thing that I'm wanting to pilot in Blackpool is a safer injecting site. And again, the Home Office won't allow us to do this because of legislation. I've shown you the chart around the young drug deaths. To tackle some of those young drug deaths, overdose consumption rooms, safer injecting sites, whatever you want to call them, have an evidence base at reducing deaths in that age group. And I'd like to pilot something, but I'm being told I can't do it under the current legislation. So these are things where, you know, government policy needs to change or allow us to pilot things, if not change legislation. So what are my recommendations for the collaborative? Well, I think we need to agree a few priorities, don't we? And let's agree maybe 3 priorities. A short-term one where we can show success and outcomes very quickly, tackling something like hypertension or depression. A medium-term one around alcohol, tobacco, and a long-term one around the best start in life. Of course, if we invest in our children and young people and giving children and young people the best start in life, that's going to reap us rewards in future years. So this needs to be underpinned by recurrent investment, and also with the lived experience team working with us and our third sector working with us collaboratively. Why not create the old joint finance system where we shared a pot we used to fund 3-year change projects? Let's all sign up to meeting need rather than demand. Stop saying they keep using the hospital as primary care. We need to, you know, get serious about that and redesign services so that they are working appropriately. The NHS system is under a considerable amount of pressure, and we really need to do something differently, because I think there is harm happening out in the community and harm happening in our hospitals. I'm hearing that repeatedly. And thirdly, why are we creating, and this may be my perception of it, it might not be true, and maybe I'm reading too much into what's happening. Why are we creating a parallel public health system and a population health system, one in the NHS and one in local government? It has to be one system. Thank you, Sir Michael. I'll stop there.
Terrific. I fear I put the wind up everybody, and so you're being shorter rather than longer, but that's terrific. Much to discuss, and it gives us time to come back. And you've set out the issues for us, the challenges, and you began with talking about funding from central government, which is not a side play, but central. Great. So let's move now to Cumbria. And please.
Thank you, Michael. Let me just start presenting then. Okay, thank you very much for the opportunity to present on behalf of Cumbria Health and Wellbeing Board. Clearly, our leader is here as well, and we'll pick up some additional observations, I'm sure, in the chat afterwards. My intention just now, I'm going to take a similar sort of approach to Arif, and I'm going to go through the 5 questions that you set for us, but I'm going to take them in a slightly different order to the ones to the way Arif set them out, if that's okay. But first of all, just to let you know about the approach that we took to answering the 8 questions which were originally set for us. We've taken a fairly wide net in this, in consulting with a range of partners to the Health and Wellbeing Board. So the questions were circulated to a wide range of partnership groups for their views and their responses. We've talked to them directly. We have a Health Inequalities task and finish group of the Health and Wellbeing Board that was set up in response to the recognition that COVID had created and illustrated lots of health inequalities, and we needed to have a view on that and take action on that. So we specifically have that task and finish group, and they've been responsible really for coordinating this response. Plus a range of other technical things, like so a survey monkey to partners, a kind of what's called easy retro boards, a shared workspace where people can effectively put electronic post-it notes up with views, and lots of email responses as well. So we've collected and then collated a very wide range of responses from partners into the 8 questions that we were originally asked, and there's far more detail in the report that we've circulated to you already. So if I take the 5 questions that have been asked by the panel, the first one I'm going to focus on is what are the main challenges to action on the social determinants and health inequalities? And the diagram here, again, I don't expect you to be able to read it all in any detail. It's in the report. Sets out, I think, part of the problem. When we asked people in Cumbria what do they think the main challenges were, they came up with so many things that it was slightly difficult to group them into a kind of coherent set of challenges that we need to focus on. So I think what that really does is illustrate the scale and the complexity of the problem that we're facing with health inequalities. And of course, in something that's that big and complex, there are a lot of actors already, a lot of people leading on some of this already. If I take, for example, housing is specifically identified here as a challenge in health inequalities, and it absolutely is. But that's not because nobody's doing anything about it. Clearly, we have local authorities, we have housing associations and others who work extremely hard and do what they can within the limits of their powers and resources on the housing agenda. And if it was easy to sort that problem out, it would have been sorted by now. So it's not enough for us to identify what the problems are. And funnily enough, it's not even enough to identify what the solutions are. You do have to resource them as well. And I know both Dom and Arif have already reflected on some of that. I'm intending to be the last time I mention resourcing, simply because, well, it's not unimportant, it's just the most obvious thing that we need to talk about at some point. The other thing that complexity brings with it, of course, is a complexity of leadership on the agenda. There are multiple strands of work within this that need to be addressed. They have people leading on them already, as I said. And that sort of complex leadership agenda is inevitable when you've got something as diverse as the action that's needed to be taken to tackle health inequalities. It's inevitably going to be multifaceted. The risk with that is that it becomes messy and contested in some areas. And we really need as a system to be able to navigate that complexity. And the final thing I would want to draw attention to in terms of the challenges is getting that sense of what we can best do at local level Because there are some things that clearly could make a very big difference to tackling health inequalities that we can't do. Redistributive taxation, for example, would make a big difference very quickly. Not our role. Our challenge, therefore, is to identify where we should best place our limited resources, both financial and human, in order to make the biggest difference, and that's not always obvious. Coming on to the question about the sectors that we need to work with and how we build effective partnerships, I mean, the glib answer to the first part of that question is, of course, all of them. When you see the range of things that impacts on health inequalities, we need to be able to work with everybody. The question is, how do you do that best, and what do we need to make it work? I'm picking out three key things from our report. The first of those is about shared models and aligned priorities. And I think my colleagues have already reflected on some of that. The prioritisation is clearly part of that, but I would emphasise the question on shared models. If we are all operating within slightly different models, where some of us are focusing on social issues and some people are focusing on economic issues, and others perhaps focusing on health service issues, and we all see things from a slightly different perspective rather than within the context of a shared model of how society works, then we are inevitably perhaps going to struggle to talk the same language. Once you've got those shared models and priorities, we absolutely need some clarity of roles and responsibilities, so that we are making sure that we're filling all the gaps as best we can, and not overlapping where it's going to cause problems. And there were quite a lot of people in our consultation that emphasised the importance of data in one way or another, actually making sure we fully understand the problem, that we share that information between each other, and that we can use each other's data to understand our own problems rather better. So that the challenge on getting good shared data and situational awareness and understanding of what we could do is very real. The third question is around foreseeing integrated care boards investing in social determinants and what support we need to shift priorities. I'm not going to presume to talk for integrated care boards on this. I think what I would say on this one is, I know people may find it impossible to believe, but I am old enough to remember the first Oneless report, which in 2002 said that the NHS was going to be financially unsustainable in 20 years unless we managed to get to what he called the fully engaged scenario, which was much more consumer engagement and control over health and much more investment and development of public health. We're not at that fully engaged scenario, and 2022 is of course less than 6 weeks away. So I think there is, as Arif has suggested, a real challenge with getting to that space. However, integrated care boards are in a different place and may well wish to invest in some of this in the future. What we need to get there, data and evidence, both about clinical and cost effectiveness. There are good examples out there of things that we know are clinically effective, that we know are cost effective in the NHS, that are still difficult to get funded simply because of the lack of prioritisation of some of these preventative services. We do need local mechanisms for appropriate funding distribution. And I know if you haven't come across it already, you will in the session feeding back from ICPs about things like the Morecambe Bay formula, which starts to look at allocating resources on the basis of things like deprivation, which can help to make a huge difference over the resources that we control locally. And clearly, within all of that, we do need appropriate leadership and governance arrangements, and that theme of leadership and governance comes through several of the strands of the questions that we've been focusing on here. In terms of the recommendations for an effective regional system, again, we've touched on system leadership and accountability, so I'll not delve too much more into that. We do need to make sure that as we work through this, we are very deliberately creating the conditions and culture for doing this correctly. people all need to understand the situation in a common way and be working towards common goals, and to have the right sort of skills to take account of the action that's needed for health, tackling health inequalities and the social determinants of health. And we can build that as a common culture. The question on sectors showed that we do need to work with everybody, so that continuation of strengthening collaborative partnership working and directly with communities, not just with agencies, needs to be really clear in our governance and priority setting. And that, again, it's easy to say, but particularly talking directly with communities and engaging communities in these formal structures is much more difficult for statutory organisations such as ourselves to do. Shared priorities and outcomes I've covered, and data sharing I've already covered. That's one of the key things for us, and increasing that investment in prevention and local funding based on social inequalities and health outcomes. So apologies, that first time that I mentioned resourcing, I couldn't quite manage to make it the last. But then outside of funding issues, what support do we need? Again, you can see a fairly clear range of things within the final report. I'm going to draw attention here to just a couple of them. Leadership and governance arrangements, we do need to get clear, and I think that the HEC can potentially help that and help us get into that sort of space. I think the HEC can also potentially support that development of the shared models and priorities that we need to have in place. Provision of evidence about the effective local action work, drawing on the challenge that I've already flagged about getting the balance right between what needs to be done nationally and what needs to be done locally. And if there are any examples out there of effective data sharing and integration that we would benefit from seeing and working with, again, we would love to hear about those from the HEC. So thank you very much. That is it from Cumbria Health and Wellbeing Board.
Wow. Well, thank you very much. Personally, my main frustration is I can't visit these places at the moment. I mean, you know, it's very hard for me to get a sense of it. But what you've just been doing is the next best thing. So thank you. Terrific. Lancashire.
Thank you, Professor Marmot, and good afternoon to yourself and your colleagues. It's a pleasure to be able to talk to you this afternoon, and for you taking such an interest in what is happening in our county. So it's a bit of a dual effort from ourselves. So I'm on the call as the portfolio holder for Health and Wellbeing and chairman of the Health and Wellbeing Board, and Dr. Sackvey, our Director of Public Health, is on as well. So I'll take you through, and if Dr. Sackvey wishes to interrupt at any point, please do, or add to the comments at the end. Professor Marmot, I'd like to congratulate my colleagues from the neighbouring councils for their excellent presentations. We're putting ours forward a little differently, so there won't be a set of slides as such, so we're just going to talk you through, but basically under a number of headings, so to give you some context and some background, to set out our immediate priorities for the Lancashire area, set out our intentions moving forwards, and how we can actually work indeed with the Health Equity Commission moving forwards as well. So for background, Professor Marmot, I became the Cabinet member at the end of May. I was given the honour of doing so by Councillor Williamson at a time of significant change, obviously. Partway through a pandemic, we did feel at that time we were probably coming towards the end of it. Clearly that is not the case, and that will continue for some time to come. Lancashire is a diverse county. It's a county which is very large geographically, with a large population, about 1.25 million, and it's a two-tier area, so we've got a county council and 12 districts as well, which makes it a little more complex. We have significant health inequalities, not just across that wide geography, but also within cities, within towns and within villages and the rural communities. So literally a couple of streets from one place to another, you can have some very significant differences in life expectancy and quality of life, etc. Our Health and Wellbeing Board understands the key drivers of health inequalities in our communities through our joint strategic needs assessments at a county, a district and the neighbourhood levels. But we are now undertaking, and this is something I was keen on when I came into the role, but we are undertaking a radical refresh of our health and wellbeing strategy and the membership arrangements for the board to make it fit for the post-pandemic world with a vision to achieve the best possible health and wellbeing outcomes for the residents of Lancashire and to reduce health inequalities across the area. As we refresh that strategy, we recognise that this will require long-term commitment. So whilst we'd like to make some quick wins, a lot of this takes time. It can even take decades. So we therefore commit to developing a 10-year plan with a particular focus on prevention and the wider determinants of health to improve our outcomes for public health. We are committed to strengthen our partnership working as well at district and neighbourhood levels with a focus of continuous improvement, and that is so important for us. So the county can give the strategic lead, but it's very much those districts and neighbourhoods who can work closer to particular populations and closer to particular issues. We're also aligning our efforts with other partnerships across the county, such as Children, Young People and Families Partnership, Community Safety Partnerships, the Enterprise Partnership, and the emerging NHS Integrated Care Board and Integrated Care Partnership. So turning to our immediate priorities, whilst we are undertaking the refresh of our health and wellbeing strategy, we have identified 3 immediate priorities to pursue as we recover from the pandemic. Firstly, to achieve the best start in life for all of our children, our young people and our families, regardless of their background. Secondly, prevention, early detection and the management of long-term conditions and their root causes. And we've got a particular focus on this, on healthy hearts and obesity, which of course are determine a lot of people's health conditions and has such a big impact upon quality of life and length of life. And thirdly, we want to improve mental health with a focus on suicide prevention, as we have some particular hotspots across Lancashire, and to promote well-being, both mental and physical, in our communities, in our workplaces and across the economy. We are in the process of now enhancing the board's system leadership, our skills of advocacy and continuous improvement capacity. Our intention moving forwards is to support our economy and our anchor institutions to improve the wider determinants of health and to reduce inequalities. We want to support our local voluntary, community faith and natural assets to give them the realisation that well-being is for everyone. Everyone has a big part to play in determining this and improving people's quality of life and well-being moving forwards. And we want to support person-centred services that place prevention and best value right at the core of what they are doing. Moving on, and how we can actually work with yourselves on the Health Equity Commission. So we'd like to be able to identify best practice and any actions that we can pursue at the local level to improve health equity across Lancashire. We would like you to have a look at our health and wellbeing strategy and to support its development and hopefully to endorse it moving forwards. And as I referred to earlier, we've had a refresh of our Health and Wellbeing Board, a significant look at it in terms of the membership and how we can drive that forward moving forwards and really focus on delivering on outcomes. It's got to be outcome focused. And the first meeting of the new board is in January, so I would extend an invitation to yourself, Professor Marmot, or of anyone else who'd like to come along and see how that works in practice. And finally, we'd like to facilitate sustainable allocation of local NHS capacity and resources to strengthen our efforts to address inequalities moving forwards. I'll leave my comments there for now, but happy to take any questions and would invite Sakfi to actually come in and make any additional comments, please. Thank you.
Thank you, Councillor Green. I would just make a comment which is to highlight the the theory of change, if you will, in terms of addressing equity and health equity that we are attempting to do, and any input from the panel would be helpful, in the sense that whatever outcome measure that we choose, we act on 3 fronts. One is, what is the local policies and local conditions that we can create, whether that is signing up to charters and creating conditions for better walking, cycling paths, or supporting families living in poverty locally. How can we integrate various policy initiatives for people across the gradient? The second front is what Colin mentioned earlier from Cumbria. How can we really achieve a fully engaged scenario with our communities, and including how can we really mobilise the natural assets which we are blessed to have in Lancashire to bear on well-being and inequalities. And then the third one is where most of the money is spent, but it's more meeting the demand. I think Arif mentioned this, rather than actually addressing the need. When it comes to delivering services for individuals, we want to make sure that in our planning going forward, that individual and families are at the centre, and that we make every contact and also every contract that we have with the services count towards equity. I'd leave it there, Sir Michael. Thank you. You're on mute.
Sorry, had you planned for any other of your colleagues now, Michael?
No, I hadn't.
Okay, great. Well, terrific. We have an hour for discussion. Thank you all so much. I'd like to kick it off, as I said at the beginning, by inviting our council leaders to give your thoughts and comments. And now we actually have some time for some questionings too, if you like. Councillor Philippa, could I start with you?
Thanks, Sir Michael. Those of you who are watching, I've been bouncing in and out because of a poor signal, so I'm not going to put my camera on because I'll probably disappear again. So apologies for that, but hopefully you can hear me okay. Yeah, just first of all, say thanks to all 4 teams actually for their presentations, which were really very interesting and useful. I think just some observations really from me, if that would help. I think there are some really bigger almost sort of governmental sort of points which I think to help in terms of legislation and national policy that I think we can note in this commission and maybe deal with in different ways. But I think where we just need to, where we can, just try and focus locally and regionally in the outcomes that we eventually come up with, if we really want to start making a difference on the ground more quickly. So that's definitely about prioritising, which I think every one of the different boards made the point about, and really homing in on the data. I was struck by Cumbria's presentation about the importance of data in all of this, and I think sometimes because we, particularly those of us working and practicing in the area, are very familiar with the issues, we sometimes don't actually sort of hone in detail on that data. And I think it's really important that we do so that we really understand the impact of what we could do if we target it appropriately. Yes, we should develop models to address all of that. I think it's really important that when we do that, we map out really clearly who is delivering. We still see examples from my experience of overlaps and not always the best fit. And throughout all of that, we just need to keep reminding ourselves that we need to be, whatever outcomes we're delivering, we need to be family and person centric. I think Sakthi mentioned that, but I think that's absolutely crucial. And the other point I just wanted to make is about the power of this commission generally, in terms of its ability to enable us here in Lancashire and throughout the Northwest to benefit from the best practice and the contacts and the networks that it has. And you know, if we can draw in some of that knowledge and best practice that's worked elsewhere, then I'm sure that we're all up for learning from that. But also using the expertise of those on the commission to help us with some of the stuff that we've already got in place here in Lancashire. As we've talked about, we're carrying out quite a fundamental review of how we go about all of those things. So all this expertise on this call and elsewhere to help us just look at that would be really beneficial. So I think from the conversations that I sort of falls into three areas for me, really. The really big strategic stuff, the stuff that we should be doing across our systems, between ourselves, amongst ourselves, but also using the collective power of this commission and its knowledge from elsewhere and its experience elsewhere to help us at a local level as well. I think we'd get real value out of it across the piece. So it's just comments from me, really. I didn't have any specific questions. Thank you.
No, that's fine. Absolutely fine. Thank you. Cumbria, Stuart Young.
Oh, thanks, Michael. I was particularly struck by, I think it was Dominic who said in his presentation, and it was echoed in the chat, that we've had health inequality targets for 30 years or more, and yet inequalities are greater than they've ever been. And I think that's the challenge for us, really. Quite a few of the speakers picked up issues about governance models and getting the right model. I think John Rush from North Cumbria CCG is on the call, and he'll know that that's a particular favourite topic of mine, because I mean, at the moment, of course, we're undergoing one of the biggest reconfigurations of the entire NHS and social care system that we've ever seen. I think it's probably visitable from the moon. And there's a complete lack of clarity as to where that's going to land, at least from where I'm sitting. And here in Cumbria, we also have local government reorganisation coming down the track. But in amongst all that, which committees are we going to have, who's going to sit on them? The more fundamental points to me are, the GP model is broken completely, and I'm not sure that we're doing enough to address that. I mean, a view from the Cumbrian perspective is that it's been broken, or it's been heading towards being broken for a long time, particularly for isolated rural communities that rely on, sometimes single-handed practices, which we've known for 20 years that when those people retired, we wouldn't be able to replace them for reasons which we well understand about not wanting to tie the money up in property, etc. And I do think that an employed model with GPs leading community prevention teams is something that would be much, well, certainly worth examining more seriously than it has been at the moment, up to now. The point really came home to me about the parallel public health and population health systems. I mean, I've been bemused by this from the start, really. We've only had public health come back to local government since 2014, and no sooner has that happened than the NHS creates a parallel service with the name population health, which is sometimes mistakenly called public health by people who work in it. And essentially they are doing the same thing. I have raised this and been told at length exactly why it's different, but to me they are doing the same thing, and it's a waste of resources to have them in parallel when we're trying to integrate health and social care. I very much agree with bringing back joint finance. I remember it well, and Section 75 agreements could be extended considerably. But the real fundamental point is that we don't have a national health service, we have a national illness service. And we do need a system that delivers it needs a budget that delivers good health rather than a contract to deliver treatment for ill health, which is how the system works at the moment. And so I think there are some structural things that we can do. I think the point I made at public health being embedded in everything that we in local authorities do, in much the same that net zero has become a bit like that now. It's an all-embracing policy and everybody contributes to it. And we've tried to do that in Cumbria, and I'm sure we've got, we can do better at that. But I do think that's a way forward. So some very interesting thoughts from all four Health and Wellbeing Boards, and I'm looking forward to us getting down to some specific recommendations as to what we can do locally, recognising the background of reduced funding from central government, which we're less able to affect. Thank you.
Great, thank you very much. Can we move to Blackpool? Lynn Williams.
Hello, Sir Michael. Thank you. I agree a lot with so I won't repeat what Stuart has just said then there, but just a few more points really, and I suppose to draw out from some of the comments that Arif have made. That was the briefest I've ever known Arif, by the way, so you really must have put if anyone has attended meetings with Arif will know. In relation to funding and levelling up and being local, I think that it's so important that, because we all know our patches, and to be able to put that local knowledge, I think is something that's so important to all of this. To be listened, to be heard. But if that devolving ever does come down to that local, we're 78% of our budget in Blackpool is on social care, and that isn't all the statutory services. So funding is a massive issue for us. The other point I would stress again is housing. We have been having conversations with government. They ask, and I cannot stress the importance of that to Blackpool. We know all the connections between housing and not doing well at school, or underachieve, etc. All those other health connections. So to enable us again, that local aspect, allow us to take control of that. Because we have in Blackpool some issues around transients, etc. And of course, all this poor, awful accommodation, is being funded from public funds. Enable us to take that and deal with that issue locally. And the other couple of points I would mention was in relation to young people and skills, that connection, and I think we need to, if we're going to have that impact that is a generational impact, we need to because focus on our young people, and that is around around education and supporting. In Blackpool, it sounds a bit of a crass comment, but we import poor health and export good health. Healthy people go elsewhere. By all those other things that we hope that may come with levelling up in terms of improved transport, would enable that people to live locally but also still have access to that increasing skills. And I think the final point was a few years ago now, it must be, I attended with Arif a meeting that was around forming a Pan-Lancashire Health and Wellbeing Board. And there was much issue, much discussion at that meeting around how the health imprint and neighbourhoods didn't correspond at all with locally, in terms of from not just council wise but ward wise, but area wise, community wise. And I think that marrying up needs to be, if that could work, because we were having discussions about levels of deprivation. It can mean one thing in one area, You know, we all know Blackpool were unfortunately at the top of the list that nobody wants to be at. But if we are going to tackle that, then we need to understand the level of it, the impact. And just one final point was around drugs and alcohol. I think that change in law, it would obviously prevent Arif being arrested, which we really would rather keep him around. But it isn't just about that. That obviously around that one person. I know I'm preaching to the converted, but the impact that has upon our, you know, schisms in families, the impact upon communities. So to be, and actually, it went through our scrutiny committee, and injecting rooms, whichever title, had cross-party support because of the extent. It's time to do something radical in that regard, and that was also from all partners that are involved with it. Last thing on partners was Arif set out the importance of partnership and the amount of work that we do with business and lots of areas. I think one thing that we have particularly learned coming from COVID is the importance of voluntary and third sector and that community engagement, and how that we need to invest and to maintain that. So we did a number of the citizens' inquiries. The one that was most successful was in my ward, nothing to do with me, but it was because we had a community worker who was then able to support that group of people, and it had legs. They defined their own how they their own priorities around mental health, and it really did some great work. So I suppose it's coming back to supporting that partnership, particularly around the volunteer third sector, who, you know, can teach us all properly about community engagement and also funding. I think that's me. Thank you.
Good, thank you. And let's go to Blackburn. Mohammed Khan. Mohammed.
Thank you, Michael. It's very kind of you setting up this board and chairing this meeting. And I think I heard 4 excellent presentations. Most of the things are very much common. I think we have been working very closely with the Lancashire Health and Wellbeing Board. I attended a number of meetings in the past. The last 18 months due to COVID, we couldn't get much engagement. And I think number of presentation, they have a kind of common theme. The whole system need to join up. That's one thing I think we have been saying number of years, and I think we set the kind of system in 2007 in Blackburn with our health system, which was working very well. And I think 2010, when the new government came in power, they abolished the whole system. We call it Care Trust Plus. When we have joined up services with health and adult social care, we transfer our budget to the health. There was one chief executive, one finance department, one legal department, etc., etc. I think that given us good opportunity to save the money and invest in grassroots level. But I think that system is gone now, and I hope the new ICS system, new integrated system, is going to join up the whole system to make sure we will be able to spend more money on grassroots level. And I think that's what we need, shifting the whole system in the health model. And I think number of presentation was quite clearly early intervention and prevention. And I think we are treating people when they ended up in hospital very much ill, but we are not thinking much about it, how we are going to prevent the people before they get ill. And I think the other issue, which is very important, building a relation with the community, and I think developing the community, empowering the community. And I think unless we empower the community, they control of their own life, we are not going to win this game. And I think in Blackpool and Darwin for last 6, 7, 8, 9, 10 years, since John came in, we have a strong communication, a strong engagement with the community. And there are many number of people, they have taken the charge of their own life. They are going for jogging, they are going for running, they are going for walking early in the morning, which was not happening there before. And I think this is very important, that unless we develop the community, engage with the community, with the faith sector, community and sector, we are not going to win this whole model. But I think a number of people already said this economic policy need to be shifted to tackle the poverty, unemployment, and poor housing. And I think the three presentation highlighted the housing issues. It's not only private sector. I think pre-1990 houses. I can talk here about Blackburn. 42% of pre-1990 houses, 2 up and 2 down, which caused great deal of problem for many number of years. And I think we have a housing market renewal fund 2005 to 2010. I think the whole Pen and Lancashire done a great deal of job to demolish some of the 2 up and 2 down authority, 2 up and 2 down houses, which really improved the quality of health for people who moved from that area into different area. And I got all the statistics there, all the data there that people who moved from those pre-1919, 2 up and 2 down, no back street, etc., their health improved great deal. The number of people are suffering the asthma and other things. And I think when we look at the doctor record, etc., they were all saying that, yes, I think that make real difference. So Michael, I think this is housing is one of the biggest problem in the whole Lancashire, and especially in Pen and Lancashire, what we see in Blackpool. And I think we need to have some kind of thinking. And I think we cannot do much about the housing. I think the private sector are probably social landlord. I think social landlord doing a good job. But even the private sector renting accommodation, there are some good landlord registered with the Blackburn Borough Council. We have a licensing scheme, but I think there are still some landlords which are not really controllable, and we don't have any much authority to control those big landlords. So I think all in all, I think if we want to improve the health and well-being of the people, we need to think about it. And I think government has to think about it, how they are going to develop the power at grassroots level, that we will be able to make our own decision. And I think economy is one of the biggest issues which are affecting people, low-paid jobs, part-time working, etc. And I think that is cause of poverty. And unless we sort out the poverty, we are not going to improve the housing. There are a number of people here who have got the houses, probably £60,000, £70,000. That's the market in Blackburn and Darwin, and they don't have much money to borrow from the bank, or probably gives him something to the bank that we will be able to pay back. So they can improve their housing unless the government will come up with some kind of initiative and give the money as they did in housing market renewal to improve the housing market in the poor area. So I think most of the presentation, I fully echo what the people said, and I think we need to move forward. That looking at action plan, what is the best to make sure we are going to improve the quality of life of the people. I think the Blackburn with Darwin Health and Wellbeing Board, start well, live well, age well. That is our strategy for many number of years, and I think the given every child the best start in their life, that was our priority. But I think the way things move forward for last 10 years, and I think Dom said quite clearly, we lost about 44% of budget, which is about £140 million, and most of the money which is taken away from the local authority, that is early intervention and prevention. As already said, that 78–80% of our budget go to social care. So there is not much power in the local government to make sure they are going to get early intervention and prevention and make a real difference. So I think, Sir Michael, I think there is a big challenge there, and I think we are here to make sure we are going to make a real difference after your recommendation, and how we are going to implement those recommendations. Time will tell. Thank you.
Thank you. It is a big challenge, but I'm delighted that everybody wants to engage with it. Can I throw it open now to general comments and discussion? And while you're thinking of that burning point you wanted to make, so for any of the people on the call really interested, either come back from the Health and Wellbeing Board presentations or others. But could I start, Joe Lappin, with you? You've put a couple of comments in the chat, and would you like to talk to those?
Yes, thank you very much. I mean, I think the first thing for me, certainly seeing the presentations that Dom and Arif did, it was really, really sobering. Because if we looked at those issues, they were the same issues we were talking about 2 decades ago. And the solutions about better system integration, prevention rather than cure, moving people into different parts of the healthcare system were all being talked about. So for me, I think we've got to think really, really differently about the solution. And how do we get serious creative thinking that breaks across institutional barriers that can actually start to change some of these things? And I think looking at it from a public policy perspective, you know, we were talking, Arif was talking about injecting rooms. We had pilots decades ago. There was a drug prevention system in Widnes that gave people access to clean drugs, dealt with the consequences, really, really improved health. But we never seem to scale up any of these things. So we have lots of disparate, really good, positive activity, but we don't seem to be able to deliver systemic change. So for me, I think it's about how do we deliver that systemic change, and how do we get people to be very focused on not process, but outcome. And one of the things that sort of struck me, because I mentioned last week, the place around whole place community budgets, and that was rethinking the system in its entirety. I think at times we need to go across organisations rather than down organisations if we want to deliver really, really different responses to things. So just very sobering for me. Not in any way daunted, but I do think we've got to think very differently if we're actually going to deliver change. Thank you.
Good, thank you. If you could raise your hand either in person or using the electronic hand raising, other comments and thoughts. Sue Cotton.
Hi, I've just put a comment in the chat as well for the group, but I found the presentations very, very interesting, and particularly the common thread throughout around the engagement and the involvement of the voluntary community and faith sector. And it's really, in terms of thinking really carefully as to how that happens, because too often I sit in meetings and it's mentioned as if we're one body of collective ideas that we all share, and we're not. There are hundreds of different types of organisations with different approaches at different sizes, and currently I am engaged across the East and across central Lancashire in particular, and I find it unfathomable at times in terms of what's going on. And I'm pretty well informed and engaged with what's going on. So I do think that for that engagement to become real, we really need to think about what the communication strategy is, what the leadership approach is. The leaders currently are doing it on top of their own jobs of running their own organisations with very little additional support or capacity, because of the way the sector has been engaged across the 4 different areas. I think at times there's a difficulty between that leadership group communicating across to the other organisations, and I really think that some focused work needs to be undertaken in making sure that there is a really clear strategy of that engagement and involvement of the sector, so that it's true and meaningful, as opposed to being potentially tokenistic and box ticking with it. And simple things, I've seen other areas that are moving forward that have commissioned, for example, a really basic website that links in across the sector so that key comms can go in there. You're looking in just one place instead of getting umpteen communications from different places. And I think a really simple thing in terms of making actual decisions and on working parties to move away from a system that it is consultation as opposed to actual co-production, sitting alongside and sharing of views and opinions. So I do think that there's a heck of a lot of will within the sector from the individuals that I'm talking to at leadership level across, who really want to be part of this, to engage and to make a difference. But I think that there's some work around how that system actually approaches that work with the sector and making sure that that we're putting some systems in that are actually more collective and engaging to get the true view, as opposed to the individual views that are being received at the moment.
Thank you. I think I said this before, but consultation, if one really did a proper comprehensive cost benefit of consultation, consultation means the authorities have decided what they want to do, and they're going to waste everybody's time by pretending to listen to people's responses. And having got them all in and wasted everybody's time, they then go ahead with what they originally wanted to do. I was just involved in one university in Australia, which notionally put out a plan for consultation, and several of us wrote in and responded, and I think it made not 1 millimetre of difference. They just continued to do. So you think, why did we all spend all that time? You know, consultation. So thank you for making the point. It's co-production's not the same thing, the consultation. Tammy.
I just wanted to pick up a little bit of what Sue was talking about, because I wanted to understand when you talked about system, did you kind of mean the NHS? Because I think that's what we've heard, is this relationship between the NHS and the voluntary sector. So that's one of the actions between now and when we leave. We're talking to some voluntary sector about commissioning and communication between the NHS. Is it wider than that, or is there something else we should be doing or talking to people about? Or who should we be talking to?
I think it's probably wider than that. I think that the NHS is an obvious one because of the changes that are happening at the moment and the discussions that are going on with the sectors, with the various leadership groups that are around, and a lot of that is focused on change within the NHS. But I do think it's broader than that. It isn't just the NHS. You sit in those meetings, and I've heard the same conversation when I've sat in a local authority meeting only the week before. In terms of it, and there seems to be a real lack of join up there. So when I'm talking about system, I'm talking about change system in terms of statutory bodies that are responsible for pulling together the overall plan, which I assume that we're then looking at how we can prioritise within our own organisations, how we meet those approaches. And so it is about, I suppose, looking back at the Health and Wellbeing Boards that have got those representations on board with them, and that systemic approach in terms of every strand that's being looked at within corporate and statutory bodies, where is that strand within the care and the voluntary system as well, so that it actually becomes an equal player. So workforce strategy, for example, is a really obvious one. It's no good it just being sat in health or being sat in social care. You've got the same workforce across the board, and how do we work with that? So it's really, I'm talking about real engagement as an equal player, but recognising we're not a corporate body. We're made up of lots of different organisations, which makes it more difficult to actually do that in a meaningful way.
Thank you. Stuart, I'll come to you in just one moment, but I'd like to get responses on housing. Several people have mentioned the importance of housing, and it seems to me emblematic of this issue of what needs central government and what can be done at local and regional level. And so the question is, what can be done? Do we have to wait for central government to change the policies on housing and make real some of the bluster about new housing that we keep hearing? What can be done at local and regional level? I'll come to Stuart, but I'd really like to hear responses about the housing question. Stuart.
Don't ask me about housing.
No, I said I just wanted to put it out there and get people to think about it. But Stuart.
Well, I'm happy to come in after you've done the housing one if you want, or because mine's on a different issue. But well, I'll go ahead if you want.
No, do go ahead, and then I'll ask people to come in the housing question.
Okay, just in terms of the whole integration agenda between health and social care, I mean, one of the greatest stumbling blocks to that is that social care is means tested, and healthcare is still free at the point of delivery, and everybody is aware of that. But the obstacle that creates is to integration is quite profound, because this commodification of what's called social care, although it's increasingly becoming blurred, makes integration really challenging. And in my experience, it's often nothing more than co-location. You know, we put two teams in the same buildings and say we've integrated them, but we haven't really. And if you entered any other part of the NHS, if you went to see your GP because you had a complaint, the GP wouldn't say, well, we need to do an assessment first, and then we need to decide how much time I can spend with you, and then we need to do a financial assessment to work out how you're going to pay for it. And all of that leads to, you know, 15-minute visits to people, which is, and the carer spends most of the time writing the notes up rather than interacting with the individual. And I mean, in the past, before all this, a lot of us are harking back to the past, but before this, when we had a home help service, you had a team of people who looked after a number of clients in an area, and they decided how much time they spent with that client, because not everybody feels the same every day. You know, they wake up in the morning and they feel quite good, and then the following day they feel terrible, so they need more time. And that whole charging system, I'll confine it to domiciliary care, not just for older adults, by the way, but for adults with enduring issues, learning disabilities, children who are requiring social care, the whole thing. And I did contribute to a report that was done by Danny Kruger, one of the government minister, in which he took on board my suggestion that the government should pilot the scrapping of charges for domiciliary care in a particular area. I put Cumbria forward as a volunteer. It would have cost us about £6 million a year to do that. And his report was completed, but you know, it's like a lot of reports. There's nothing that has come out of it. But I do think it might be something that this commission takes up about the problem, and having a real conversation about, you know, is it right that somebody who has, as it was defined by one minister many years ago, if they have a condition that wouldn't benefit from active medical intervention, then it's classed as social care and you're going to have to pay for it. And that is really at the heart of the difficulty in creating a truly integrated health and social care system.
Thank you. Very important point. Arif, oh, you're back. I was about to say, I noticed your hand was up, then it went down.
Hi, it's Michael. I wanted to come in on the housing issue, if you,
yes, please,
if you don't mind.
Yes.
I mean, there's a few things we're doing at a local level, and John and Lynn may want to comment after me as well. As a local authority, we're sort of uniquely placed to addressing some of the housing supply issues. So as a direct provider and also enabling private and sort of social housing development. So new housing supply is something we can do, and that's sort of under our control to a degree. Improving the private rented sector. So what we're doing in Blackpool is that we've created an arm's length company called My Blackpool Home, which is starting to buy up some of these HMOs. And so we're becoming a landlord by buying up those properties, improving those properties, and changing those properties from HMO use to more family use where we can as well. So we're intervening in the private rented sector that way. Along with that, previously we've had tranches of funding to address the you know, stabilising the lives of people in those properties as well, you know, starting to tackle some of the social and health problems of people in those particular properties. And where we've had money to do that, that's been really effective, where our housing officers and our health colleagues work very closely together to address some of those health and care issues in that client group. So those are the things that we can do as a local authority. The thing we're hamstrung by is the fact that housing benefit is determined at a national level. So regardless of the property so if you buy a 3-storey terrace property in Blackpool at a cost of £70,000 or £80,000, you turn it into 8 HMOs, you get £80 a week on housing benefit, times that by 8, that's £640 a week, times it by 52, you can see how that is a really great moneymaker for a private landlord, most of whom have never been to Blackpool and don't know Blackpool at all. They're just making money out of it. The problem with that model is obviously there's no standards to that accommodation, no money is put back into those properties, and what ends up happening is people who have a problem where they are migrate into Blackpool because they're running away from whatever issue they've got. They've got a positive memory of Blackpool when they were a child, and so they up and leave and end up in Blackpool with a black bin bag and go into one of these crummy HMOs and often have health and social problems already. So we as a local authority and the NHS are then left with picking up the pieces for those individuals when they come here. Obviously that increases our demand, and just Lynn described it as we import ill health and export good health, because of course when you get back on your feet you don't want to live in a crummy HMO, and that's the issue that we've got in Blackpool at the moment. So the task is to reduce the supply of HMOs. We've got 4,000 of these HMOs, so it gives you an idea of the scale of the problem. And the reason we've been left with those HMOs is because over the years, as bed and breakfast business has declined with tourist numbers, tourism has changed, hasn't it? So people come for day trips and short stays rather than for long periods of time as they used to do back in the day. Those businesses have had to turn to a different sort of business model, so they've gone from being bed and breakfasts to being HMOs, and that's how they make their money, and that leads to the issues that I've just described in terms of the migration into Blackpool. Now, people often say to me, well, if they weren't coming to Blackpool, they'd be somewhere else. You're just displacing the problem. That's not the issue. The problem is when you get lots of vulnerable people coming into an area in a concentrated way, there are other people there to prey on that vulnerability. So you've got your drug gangs, your drug pushers, your loan sharks, all those things come into play with those concentrated areas of vulnerable people, and that's what we end up getting in those HMOs. I hope I've described the issue there, and the problem is that yes, we're doing everything we can at a local level as much as we can. Yes, of course, we could do a little bit more with the help of the NHS investing in some of those services that I talked about around stabilising lives. But it's also about government being able to flex the policy and maybe pilot it. I always say to government around the drug policy and overdose consumption rooms, and also around housing, don't change legislation, give us a pilot area. Let's do it locally and evaluate it, and then if it works, you can then go away and talk about changing legislation. Thanks, Michael.
Thank you. John Donlan.
Thanks, Michael. Yeah, I mean, I agree with loads of what Iris just said, really. And I suppose the housing issue for us is really that we've got a market and a government policy that is just dominated by numbers and money. That's what determines what is produced, really. Now, the company I run is wholly owned by the council. It's got a real local focus. So we almost act like a guerrilla agent in terms of housing, if you like, because we're trying to meet some of the council objectives around outcomes for people in our locality, not trying to just meet an appraisal or a set of numbers that's imposed from Westminster. So trying to sort of give you some sense of what that means, really. We just knocked down 74 horrible bedsits and put back sort of 74 family homes, and we've been able to do that with council budgets. Our HRA has done that because we've forgone any land value, If we ran that through a government appraisal or a private sector appraisal, we wouldn't have done it because it wouldn't have paid. And you'd have had the sort of things that Iris described. You've had somebody looking to build HMOs, or worse than that, sort of mock supported housing where people get access to benefits by saying they're providing a level of support for people, which they don't tend to do. So it's a really distorted market, I think. And for me, you would change that wholly if you devolved a lot of powers locally, so that you had local people determining what was being done in housing policy, what was being built and provided based on what was needed locally, not what a market appraisal said or a developer can achieve. Arif's absolutely right. We've got a housing market in the area on PRS, private rented sector models, that has some of the highest yields in the country. If you looked at what it provides, you would just say, how can that be the highest yielding product in the country? You know, at one stage, the yields were nearly 12% in inner Blackpool. And I mentioned this to the Homes Community Agency the other day, what you've got is government investing in misery. It's all government funded. You know, this isn't a private sector funded partnership. It's all government funded a housing benefit. And that cannot be right. That just cannot be right. But it's all seen through a Westminster prism. So I think if you devolved a lot of that locally, we would be talking about, if you want housing benefit, you've got to deliver a level of quality that would meet health needs, that would provide space for people to do their homework if they're at school, or have enough room if you've got a wheelchair, for example. You wouldn't be providing just the bare basic minimum, not even sometimes category 1 standards of health and safety, and still get your benefit. So I think some of those sorts of changes are absolutely vital if you're going to shift the market. I'm sure we'll continue to do what we can locally, as other people will do as well. I think Tammy raised the point about my Blackpool home. Could we scale it up? But you can only scale it up if you take a degree of risk locally. And there's a limit to what you can do because you're fighting a market that invests in providing really low quality.
Thank you. I mean, I think it relates to the kind of statement that we want to make, which is we may not be able to change government policy, but by golly, we've got to make a clear statement about how things could be done differently. And the whole idea, I think your phrase was government-funded misery, or government-funded investment in misery. I think we're going to use that. Thank you.
No charge, Sir Michael, no charge.
Sakti.
Thank you, Sir Michael. I'm going to focus on a slightly different aspect of housing. I think we've heard a lot about the national and how the structural regulations can actually help. We do have a lot of really good housing associations in our county. I mean, almost everybody that I know are fantastic, and we often don't treat them as a trusted partner when it comes to addressing some of the services that people get through our housing association. And I'm using Burnley as an example. We are a two-tier authority. We work with our district councils to influence housing, but we do buddy up so well in supporting people that live in these accommodation. And my point is, we can still do a lot of good stuff locally in supporting people if we get behind as a system the housing associations, the brilliant ones that we actually have already. And I see those actions happening at least in 5 different areas. The first one obviously is treating them as a trusted partner in addressing health equity as a right and centre, given that we've heard that so far. The second one is data collection. How many of our care records actually have housing status or quality of housing on the care records? I think we've talked about it as ethnicity being recorded. I think housing is a fundamental data field that we need to see in our care records, so we can really help target, identify individuals that may need that extra help. The third thing is support to people. We've said keeping people at the centre, and often the housing associations that we work with, we are involving them in whether it's mental health or accident prevention or drugs and alcohol, food poverty. I think there is an example there that we probably need to look at how some of these good practice examples work and opportunities for scaling up on a practical level, at a neighbourhood level, and indeed across our places. The last point is funding. Funding, not from the government, but funding as a way of resource allocation that's of shared benefit between the NHS and wider partners. And my colleagues here, public health colleagues particularly, will be very familiar. Every year we go with the cap in hand, just before we plan for cold weather, especially for supporting people with COPD and multiple long-term conditions in preparation for winter. Can boilers be prescribed? I think the answer has been very patchy. And I think that some schemes like that, we need to understand how the core benefits can really be spread across the system and not seeing prescriptions as only for pills. And it can be for boilers too, or indeed all the housing, whether that is falls prevention is another example. We've written loads and lists of business cases for falls prevention that's based on housing interventions, but we are finding it really hard to help colleagues see the core benefits of investing in housing across the health and care system. So I think we can certainly do some practical stuff. And Arif, we work with Blackpool Council, actually leads the county on the Cozy Homes in Lancashire as a programme. We've actually invested as local authorities in improving fuel poverty. That's a really good scheme that I think as an example of good practice we must highlight. So we already do a lot of things, but it just needs a little bit of change in the mindset about when it comes to understanding housing as a trusted partner and investing in housing as a core benefit, both for healthcare and indeed housing in itself. And data collection, absolutely fundamental. I think if we can't crack it, I'm not quite sure who will. Thanks.
Very helpful. My intention in raising the question of housing wasn't that should be our primary focus, but several people had mentioned it, and it seemed to me emblematic of the question of what can be done locally and what needs national action. And what I've heard is a combination of, well, yes, we do need national action. Secondly, we don't want the national policies to get in the way of what needs to happen, to government-funded investment in misery. Thirdly, there is local action going on that can show what can be done. Let me just pick up a few things that I heard today in the extraordinarily interesting presentations. I love the picture of the elephant in the room. You made it actually real, that slide with the elephant in the room. As everybody said, I'm not going to talk about funding anymore after I've talked about funding, and I'll try not to talk about funding, and I won't again mention the word funding. So we do have to say something about funding. There's no question that we do, even if we can't control it. But I mean, if the clear message is, and you've heard me talk about this, if the clear message is that you've spent a decade cutting funding to deprived areas, and then you say we're going to level up, it's a bit like taking £6 billion out of universal credit and putting 2 billion back. Isn't that wonderful? It shows how generous you are. Well, that is an elephant in the room, and we do have to mention it. The second thing that came through very clearly from all the presentations is the importance of data and evidence. I like your point, Sakti, that recording housing, yes, we record age. I remember many years ago, I was part of a discussion where we were trying to get, at the Medical Research Council, we were trying to get people doing clinical trials to get some measure of socioeconomic position so we could look at inequalities. And these clinical trialists said, why would we do that? Why would we do that? What's the point? And I said, do you record gender? Well, of course. I said, why do you do that? And there was a long pause. I don't know why we do that. Well, maybe you do that because the outcome might be different in the two genders. Yeah, maybe that's why we do it. Would that be a case for recording some measure of socioeconomic position in case that influences the outcome? I hope we wouldn't have that same conversation in the same way now, but it's what you're saying. Measure housing as part of your data collection. It's pretty key. And in our work with Greater Manchester, certainly we talked about beacon indicators that we need to collect. So the data is absolutely key. The next point that I heard everybody thinking it, some said it more loudly, the others thought it and hinted. What's new? This is not a new issue. Why are we going to be different this time? And we need to address it. In one sense, I've been addressing it since I started doing with the World Health Organization Commission on Social Determinants of Health. People said, what's new about this? And I said, well, even if there were nothing new about it, saying it again is worth doing. Secondly, there's lots of new evidence. And thirdly, we need to show how you can make a difference. So saying it again, looking at the new evidence and showing how we can make a difference is vital. But if we just become a repeat of failed promises from the past, that's not going to be very helpful. And related to that, I think everybody focused on the issue of delivery mechanisms. And that's going to be key as we go forward. Thank you. It's interesting, your mention of Wanless. You said you're old enough to remember Wanless. So am I. And something that Derek Wanless said about off the record, as it were, not in his report, at a meeting we were at together, and we were talking about cost-benefit analysis. And Wanless said, if the Treasury wants to do something, they don't ask you for your cost-benefit analysis. They just do it. If they want to invade Iraq, they don't ask, is that cost efficient? They just invade Iraq. They do it. And it's only if they don't want to do it that they ask for the cost-benefit analysis. So I'm not saying we should ignore the costs and benefits of different approaches, but it's worth bearing in mind that we've got a lot of good reasons for doing things, apart from whether they're efficient. The next thought that I had listening to this is, many of you said in one way or another, there's potential real power of this commission, and we need to make sure that we use that power to bring people in locally, to make a statement nationally, to show how things can be done and be done differently, because there certainly ICSs present threats and opportunities. As Stuart's point about trying to bring a universal service and a means-tested service together, is that problem's not trivial, and absolutely vital. And I was thinking related about housing, of what John Donnellan said. about local action. When we were doing the Global Commission on Social Determinants of Health, and the Self-Employed Women's Association in Ahmedabad, in Gujarat, in India, one of the many issues they were dealing with was housing. And they said, you know, if we went to the World Bank, it would cost a huge amount of money. There'd be standards and goodness knows what. So they worked it out locally. They took local action, and they did it low cost. I've seen what it looked like before, and I've seen what it looked like after, and it's dramatically changed. What they didn't do is what, if they got some international agency involved, would have done, is raise everything to the ground and start again. They modified what was there and improved what was there. But local solutions. So John, what you said, I think, wow, let's try and build on that. Extraordinarily interesting. We're on a journey here, and thank you so much to the Health and Wellbeing Boards for all the effort you put into those presentations. Extremely helpful, and we will look at them at some length afterwards and deliberate on them. Tammy and Jessica, are there any points you wanted to add?
No, just to say to the panel that we have another meeting, and to everybody, we have another meeting next week with the ICPs who will be presenting evidence to the panel again. We have then had a series of meetings, one focusing on community participation. Then we get into the important process of deciding on key priority recommendations, and we'll be developing a kind of action plan, and we hope to consult all of you who've been involved in the discussions with the panel, and some of the other people we've been involved in discussions with. We're having workshops coming up around the role of acute trusts in tackling the social determinants of health, and there's been a huge interest from the acute trusts in thinking about how they can do that far more effectively. Similarly with primary care, there's also another additional workshop on housing. Is that it, Tammy? Have I missed any off? I think that's it. So we're very busy and we're still consulting widely, and thank you very much again for your contributions today.
Can I just pop in? Sorry, could I just say one thing quick?
Yeah.
Just to say, I've just popped my email in the box to say if anyone from the HEC or otherwise want to get in touch to talk about some of these issues, because I think we've heard from some of the councillors and other, but not everyone. These thoughts may come to you in the next few days, so please do stay in touch. That's all I wanted to say.
So once again, thanks everyone, and we will meet again soon. Thank you.
Thank you.